What is a 99214? Really? I recently did a video about what is a level 5, what are the components of a level 5, what needs to be in the documentation to support a level 5 service, meaning a 99205 or 99215 in the office and outpatient setting based on the AMA guidance. At the end of the video, I asked you guys want me to go through the rest of the office outpatient levels, and I heard a resounding yes. By the way, if you're new here, I'm Victoria. I'm a medical coder, auditor, educator, and content creator, and on my channel, I provide tips, tricks, and tutorials to help you be successful in a medical coding career. If you haven't already, highly encourage you to subscribe, hit that notification bell so you can get alerts when I post new episodes. Now, I've posted a lot of videos about evaluation and management, so if you're looking for methodology on the history exam, medical decision-making levels that are still in existence for things like our inpatient visits, you can check out those videos on my E&M playlist on the channel. I've had a couple of people reach out recently and say, hey, Victoria, can you go over the 2022 changes? Well, there really aren't a lot of changes for 2022 in E&M, at least not on our office visits and inpatient visits. We will see some in 2023. But what I would suggest you do is if you get a 2022 CPT book, anything that has been changed as far as guidelines and codes will be notated. So any guideline changes are in green. And if you flip through, you can see none of the guidelines for office outpatient or any other E&Ms have really changed. There was a minor change from the 2021 to the 2022 version of CPT on the definition of code 99211. In the 2021 version, the definition of a 99211 says office or other outpatient visit for the evaluation and management of an established patient that may not require the presence of a physician or other qualified healthcare professional. Usually the presenting problems are minimal. But if you look at the updated version in 2022, they actually got rid of that last tiny sentence, so it no longer says usually the presenting problems are minimal. I'll actually do a video on 99211s because I think that's an important one to cover. There is a lot of confusion about what we commonly refer to as the nurse visit, but for this video, we're going to talk about 99214, so our level 4 office outpatient visits for new or established patients. Now, as a reminder, your new versus established patient definition is in your CPT manual. If you're looking at the 2022 version, it is on page 6. And it states that a new patient is one who has not received any professional services from the physician or qualified healthcare professional or another physician qualified healthcare professional in the exact same specialty and subspecialty who belongs in the same group practice within the past 3 years. And we talked in my level 5 video about how there are some specialty practices that do have subspecialties. A very perfect example would be pediatrics. So they might have a pediatric cardiologist within that same group practice, but that's a different subspecialty of pediatrics. Or they might have a pediatric neurologist. So that's another subspecialty of that specialty. I had someone recently comment on one of my videos saying, hey, they can't make this easy, can they? Well, medicine isn't easy. But I digress. Let's talk about our level 4 services. So one of the things I emphasize with a level 4 is it's the most common level that gets billed. If you look at a lot of the bell curve data in E&M from most specialties, you'll see that there's a low level of 1s, 2s, a little bit higher of 3s, and then it kind of peaks at a 4 and then goes back down for the 5s. And what I mean by that is that's kind of the amount, the percentages of how many different levels you're billing. So if we look at level 1 through level 5, most people are billing more level 4s. So when I'm looking at a note, I'm going to kind of target, can I meet a level 4 service? Because that's the most common one billed. And honestly, I kind of target the two main things that I see the most for level 4s. And that's the 2 or more stable chronic illnesses and prescription drug management. If I can meet those two criteria, 2 or more chronic illnesses and prescription drug management, I know I have at least a level 4 service. So in those cases where I've met at least my level 4, I'll go back and check, okay, could this also be a 5? If it doesn't, I stay at my level 4. And then that's when I go back and go, okay, now I'm going to look at the other components here. Is there any time components that might change that level of service? Is there prolonged services? And then what other procedures or CPTs can I be billing out of this? And then I go back and capture all of my diagnoses. You can do it whatever way feels more comfortable for you, but that's kind of my mindset when I'm tackling an office E&M, is I look for that level 4, see if I can at least get that level 4. I look for things like time. I look for things like if it's an attestation for a resident in a teaching physician facility. But for me, since I know statistically it's high probability that it's going to be a level 4, I target that level 4 first, see if I meet that criteria. And if I don't, then I'll go down to level 3 and see if I meet that criteria. But let's take a look again. What is our level 4? So our level 4 is 99204, 99214. 04 is our new patients. 14 is our established patients. And that is a level of medical decision making that is moderate. And in order to hit the moderate, it's based out of 2 of the 3 elements of medical decision making. So we have to hit 2 of these 3 elements. This one here, and this one here, 2 of them. Let's start with this number and complexity of problems addressed. So the moderate level. The key thing I want you to look at here is this word or. So or meaning we don't have to have all of these. We just need to hit one of these. This or this or this or this or this. So if we hit, for example, just the one acute complicated injury, that meets that moderate number and complexity of problems addressed. We just need one of these bullets here. So if bullet 1 is 1 or more chronic illnesses with exacerbation, progression, or side effect of treatment. What differentiates the moderate versus the high is this word severe in the high. So a moderate is that one chronic illness with an exacerbation of progression or a side effect of treatment, but a high is a severe exacerbation, a severe progression, a severe side effect of the treatment. And that is really the key term that you need to look for, or the key factor that you need to look for to differentiate between the moderate or high there for that category. Also, we have 2 or more stable chronic illnesses, and that's that provider is addressing them. Not that they just have the existence of it, but that specific provider did something to address those 2 stable chronic illnesses, which honestly, for a lot of internal medicine doctors, I mean, that's not hard to hit. You know, if you're a family physician, chances are good that a lot of the patients that you're going to see are going to have hypertension and hyperlipidemia or diabetes and some kind of chronic condition. So 2 of those that are just stable, that will hit the moderate category. Next, we have our one undiagnosed new problem with an uncertain diagnosis. The example they give commonly for this is a breast lump. It could also be something like if you're having pain on your side and we don't know if it's a gallbladder or what the heck it is, so we have to go and send you for more studies because we're not sure at that point what it is. It's an uncertain diagnosis. And then we have our acute illness with systemic symptoms, and I think they give some examples of this too. So let's take a look at our guidelines here. So when we're not sure about something, it's always good to reference back to the CPT guidelines that the AMA gives us for these office outpatient visits. So it says here that an acute illness with systemic symptoms is an illness that causes systemic symptoms and has a high risk of morbidity without treatment. So something that's not just going to resolve on its own like a cold would. You're going to get over a cold eventually, but something that is very risky that it could cause you some morbidity if you don't get it treated. For systemic general symptoms such as a fever, body aches, and fatigue, and a minor illness that may be treated to alleviate symptoms, shorten the course of the illness, or to prevent complications, see the definitions for self-limited or minor problems or acute uncomplicated illness or injury. So that's like saying just because you're coming in and you have a headache, but then you also have like fever and body aches, that doesn't count it as systemic. That counts it as still that minor self-limited more problem. And then it says systemic symptoms may not be general, but may be a single system. Examples may include pyelonephritis, pneumonitis, or colitis. Now keep in mind that it says systemic symptoms, so an acute illness with systemic symptoms. You can find online examples of systemic diseases, but that's not what we're talking about. We're talking about an acute illness that has systemic symptoms. And then the last one we have here is one acute complicated injury. So it can't just be an injury by itself. It has to be some sort of complication of that injury. Maybe they had, for example, a concussion with a brief loss of consciousness. Now, if we look at the next moderate element, it says here for amount or complexity of data to be reviewed and analyzed, we need to have at least one of these 3 categories to meet this element. So category 1 or category 2 or category 3. And actually the only difference between the moderate and the extensive level is this is 1 out of 3 for moderate, extensive is 2 out of the 3, but the actual data here is the same. Actually, let me zoom this in a little bit more so we can see it just a little bit clearer. So for category 1, it has to be any combination of 3 of the following, and that doesn't mean it has to be 3 of the 4 bullets. It could be just 3 orders of each unique test. It doesn't mean that they have to order a test and do an assessment. They could just do 3 of the ordering of each unique test, and that will meet that combination of a 3. You can actually verify that here in the guidelines where it says test documents, orders, or independent historians. Each unique test, order, or document is counted to meet a threshold number. And then we have our category 2. Category 2 is the independent interpretation of tests. So independent interpretation of a test performed by another physician or qualified healthcare professional that's not separately reported. So we're not billing it out with a separate CPT code, because if we are, then we're getting paid for it there. We're not also going to double dip then and calculate that in for a higher E&M level. And then category 3 is our discussion of management or test interpretation. So discussion of management or test interpretation with an external physician or other qualified healthcare professional or appropriate source not separately reported, again, that we're not billing out for separately with a separate CPT code. And if we look at our guidelines document, it even tells us what an appropriate source is. So if you just click that Control F to find and even type in appropriate source, or basically any term you want to look up, you can find quickly that definition. So appropriate source, it says, for the purpose of the discussion of management data element, an appropriate source includes professionals who are not healthcare professionals, but may be involved in the management of the patient, someone like a lawyer, a parole officer, case manager, or a teacher. It does not include discussion with the family or informal caregivers. So appropriate source versus independent historian are 2 different concepts. An independent historian can be a parent, guardian, surrogate, spouse, witness, etc., etc., etc. Appropriate source is not. Now, the interesting thing about the risk element now is it states that there is a moderate risk of morbidity from additional diagnostic testing or treatment, but it only provides examples. I see a lot of the prescription drug management. They're either prescribing something new, they're telling a patient to discontinue something, or they're telling the patient that, yes, you should still continue to take that medication or refill the medication. My Medicare contractor definitely says that refilling a medication is still considered prescription drug management when it comes to calculation of an E&M level. Others may have different interpretations. So again, keep in mind about those Medicare contractors that might have slightly different interpretations. So these are some of the categories of things that might be moderate risk. These are just examples. So there might be other things that could fit into that moderate level, but aren't exactly these. So we have the prescription drug management. We have decision regarding minor surgery with identified patient or procedure risk factors, not just the general, oh, you're going to be under anesthesia, you're going to have a risk of just having surgery, but specific to that patient. And again, minor surgery doesn't necessarily mean the Medicare definition as far as major or minor. So the minors in Medicare's mind is the 0 or 10-day global periods. Major is our 90. AMA has said they're not necessarily going to go by that. They're going to go by whatever the physician clinically decides is a minor or major surgery. Can make it a little hard for a coder to interpret that, but you can develop internal policies that just say, hey, this is what we go by. We've decided that we're just going to go by what the Medicare definition is for a minor or major surgery. Although keep in mind that I am not a legal professional and this is not legal advice. The next one is decision regarding elective major surgery without identified patient or procedure risk factors. And the next example, the final one we have, is diagnosis or treatment significantly limited by social determinants of health. So social determinants of health are things like the patient's homeless, they're in foster care, they are illiterate, they have a stressful work environment, so maybe they're a trucker, they can't stop as frequently as they would need to take medication, or maybe they're working extended amount of hours. You'll actually see these listed in your Z codes for your ICD-10-CM codes. There's a lot of them there. They classify them, though, as persons with potential health hazards related to socioeconomic and psychosocial circumstances, Z55 through Z65, although there might be things that don't fit necessarily into these categories. But for example, most patients, if they have diabetes, you can just prescribe them insulin. They can keep it somewhere refrigerated, but a homeless patient might not have access to refrigeration. So their treatment plan is going to be significantly limited by their social determinants, by the fact that they're homeless. So if we put this all together, again, we need 2 out of the 3. So we could have a patient that has independent interpretation of tests, and they have one acute illness with systemic symptoms. or they have one acute complicated injury and we decided that there's going to be minor surgery, but there's some risk factors involved. We just need to hit 2 out of these 3 elements. They're all determined to be moderate, so moderate level of complexity of problems, moderate amount of complexity of data, and moderate risk. So we would need 2 out of those 3 to hit a level 4 service. I hope you found this video helpful. Again, next time we're going to go through level 3, then we'll go through 2, and then I'm going to do a great video, I think, on those level 1s. I've actually been wanting to cover level 1 for a while because there's a lot of confusion about procedures in level 1 services at the same time and the 25 modifier and how that all works. I think this is a really important series, and actually there's going to be some changes for E&M coming in 2023, so those will probably be coming later in the year as we get more information on exactly how those are going to look, the finalized documentation and education tools. But for now, if you need more help on evaluation and management coding, this is the playlist you want to check out. I will see you guys in the next video, and until then, just keep on coding on.